This film is intended for eye surgeons for training and education purposes. The viewer's discretion is advised. Hello friends, welcome to Abhinav Eye Coach, and I am Dr. Abhinav Prakash from New Delhi, India, Prakash Eye Center. Today we are going to see the surgical video of routine cataract in which we will perform tilt and out technique, and let me tell you, this technique is very efficient in managing mild to moderately hard cataracts up to grade 2 to 3. The efficiency is very good, and once you master it, you will never regret that you have learned this technique. This technique gives you excellent results, very decreased post-operative inflammation, corneal edema, and other things, other complications like increased intraocular pressure. So let's learn this technique. So after introducing intracameral preservative-free lignocaine into the anterior chamber and viscoelastic to flatten the anterior capsule, we'll start with the continuous curvilinear capsular axis, and I perform both continuous curvilinear capsular axis with bent 24 gauge needle and capsular axis forceps. Both are equally efficient for me. And after performing the axis, we are going to make the main port with the help of 2.4 or 2.2 millimeter keratome. The main port incision should be absolutely square and strong. It should be triplanar. And now we perform the hydrodissection. We pass continuous fluid BSS underneath the anterior capsular margin, and you can see the one pole of nucleus tilts out of the capsular bag. So this is what we want. Now, to start with the phacoemulsification, we embed the tip of the phaco probe into the core of the nucleus and bring the chopper edge towards the tip from the other side. This divides or squeeze the nucleus between the two, and this is how we get the nucleus divided into two halves and then further divided into other quadrants. So you can see we are very much far away from the posterior capsule, and we are working at the pupillary plane. The endothelium is also very much protected, and we are very safe and very less fear of breaking posterior capsule. And chopping and phacoemulsification becomes very easy. Our phaco tip should be occluded all the time. The only principle is very judicious use of phaco power, and the epinuclear plate is left behind. We grab one edge of the plate and take it into the phaco probe. Now the phacoemulsification is done. Now we are left with the cortical material. See, the whole process of phacoemulsification took few seconds, not even a minute. Now we start with the irrigation and aspiration with the help of coaxial probe, and cortical matter is aspirated. Subincisional cortical matter has to be aspirated very carefully. Now few polishing needs to be done. Polishing is done, and see how beautifully the case is almost over. You can see the round capsular axis margin in the retro illumination. Now we'll fill the bag with the viscoelastic material, mostly cohesive, and Now we prepare to load the lens. Once the lens is loaded, this is the technique of single piece acrylic foldable IOL. We keep the haptics on the optic, both the haptics, and close the cartridge tightly. The lens should be towards the injecting portion of the cartridge, and injecting the lens, first leading haptic directly into the bag and trailing haptic is dialed into the bag. So it's hardly 5 to 6 minutes case. The lens is in the bag, viscoelastic removal is done from all the haptic area from behind the IOL. I hope you must have liked the video. Thanks for watching. See you again in the next video. Thank you. So thanks for watching the video. I appreciate your patience and see you for the next time.